Good evening, everybody. Welcome to the first edition of the AAHS Hand Journal Club, Hand in Focus, with the theme of Carpal Tunnel Syndrome. Thank you, everybody, for taking time out of your busy schedules to join us tonight. My name is Harvey Chim. I'm from the University of Florida, and together with Eberlin from MGH, we'll be moderating tonight's session. We'll be discussing two papers tonight. The first will be the sensitivity and specificity of nerve conduction studies for diagnosis of carpal tunnel syndrome, a systematic review. And we have Doctors Dimino and Fowler to discuss the paper with us tonight. And the second paper we'll be discussing tonight is ultrasound evaluation for incomplete carpal tunnel release. And tonight we have Doctors Tulipan and Rivlin to join us to discuss their paper. Our expert for tonight is Warren Hammert. He's a professor of orthopedic surgery and plastic surgery and chief of the Division of Hand Surgery in the Department of Orthopedics and Rehabilitation at the University of Rochester in New York. And we're honored and very happy to have him to join us tonight as our expert. So for the format for tonight, we have hand surgery fellows from the University of Pittsburgh who will first present a synopsis of each article. We have Dr. Gauss and Dr. Rodriguez joining us. And for each paper, this will be followed by a discussion by the authors, followed by a discussion by our expert, Dr. Hammert, followed by an open question and answer session. So please mute your microphones and please make sure that your camera is off while the speakers are presenting. Your cameras can be turned on for the Q&A.
Yeah, we'd also like to ask you to ensure that your Zoom name is reflective of your first and last name. And we really want this to be interactive and would love for you to ask questions. I'm sure everyone is familiar with the Zoom format, but the chat function at the bottom is the best way to ask questions. And what Harvey and I will make sure that we do is to incorporate your questions into the Q&A session. So please use the chat function at the bottom. And we'd like this to be engaging and interactive.
So without further ado, I'd like to welcome Trent from University of Pittsburgh to present our first paper. Please go ahead.
Trent, I think you're muted.
Can everyone hear me okay now?
Yes, we can.
Okay, I'm just minimizing the camera window. All right, I'll go ahead and get started. So I'll be presenting a paper on behalf of Dr. Fowler entitled The Sensitivity and Specificity of Nerve Conduction Studies for Diagnosis of Carpal Tunnel Syndrome, Systematic Review. And so carpal tunnel syndrome, just a bit of background information. The most common upper extremity entrapment neuropathy been estimated to occur as an incidence of 0.1 to 10% in the working population, as high as 14% in the general population, with an incidence of 376 per 100,000 person years. Also important, it's estimated to be a high cost of healthcare dollars per year at $2 billion. And there's roughly 500,000 carpal tunnel releases per year. So we're all familiar with the symptoms of carpal tunnel, including pain, numbness and tingling, weakness. And overall, I think the most important thing here is it can impact patient lifestyle and livelihood. So as far as making the diagnosis, there's certainly clinical diagnostic maneuvers that are the cornerstone, as well as history. We're all familiar with the Phelan, Snails, and Durkins and other objective tests that are listed there. But these have a wide range of sensitivity and specificity. So as an adjuvant to diagnosing this in the patients, oftentimes we'll order electrodiagnostic testing, which is comprised of nerve conduction studies as well as electromyography. The EMG findings can be, occur in a long-standing disease as well as a more severe carpal tunnel. The nerve conduction studies are often comprised of two main things that we look at are the distal sensory latency as well as the distal motor latency. And so the utility of the nerve conduction studies has been debatable in the literature. Its utility is a function of its cutoffs. So you want to maximize the cutoffs to reduce your false positives and negatives, as you can see on the statistical graphs there. And the best cutoff points are unknown as far as maximizing the sensitivity and specificity. They are multifactorial, which is it's dependent upon population incidence in the population that you're testing, as well as what you're referencing for your gold standard. So many authors have questioned, do you reference thenar atrophy, which can be, again, more associated with severe long-standing carpal tunnel? Do you have just hand numbness with complaints that patients bring to clinic as well? So the study was designed as a systematic review because there's a relative positive high-level studies on nerve conduction studies, specifically regarding the sensitivity and specificity. So the purpose was to review current literature, report these cutoffs for the values pertaining to carpal tunnel syndrome, and then instill any guidelines or elicit any guidelines for future management and also treatment of these patients. So several inclusion-exclusion criteria you can see depicted here. Inclusion criteria was English language, levels of evidence in these studies of 1 to 4, and then reports of either the sensitivity or specificity for at least one of the 2 criteria for distal sensory latency, as well as distal motor latency for carpal tunnel using nerve conduction studies. Exclusion was non-English language papers, as well as peripheral neuropathy patients, cervical radiculopathy patients, and non-applicable data. So you can see how the article breakdown here in the systematic review was at the end, using those inclusion-exclusion criteria, and after going reviewing of all the articles, there was a total of 21 studies included. Results here are looking at the reference standards can vary in the literature for using distal motor and sensory latencies. Some our authors have used controls, patients without carpal tunnel syndrome, and using plus or minus 2 standard deviations. Others have used as their reference standards a clinical diagnosis of carpal tunnel syndrome. Overall, in those 21 articles, there was roughly 1,200 control hands with 14 studies, and then 3,000 patients with carpal tunnel. 21 of those studies reported sensitivity. Only 7 presented specificity. Both the distal motor and the distal sensory latencies were presented in 11 of those 21 studies. And then further breaking down the results for the distal sensory latency and distal motor latency in this review. So for the sensitivity for distal sensory latency, it was 19 studies. And then you can see that there's roughly almost 2,000 carpal tunnel positive patients in there with roughly 1,000 control hands. As far as the specificity, there were 6 studies again with roughly 500 carpal tunnel positive patients, as well as 460 controls. The mean cutoff for the distal sensory latency specificity was the 3.37, with the range included 2 to 8.4. And then the weighted sensitivity and specificity looked at, it was 73%, and then 93% with specificity. And then regarding the distal motor latency, again, 19 studies with almost 3,000 carpal tunnel positive, looking at the sensitivity, and then specificity at 6 studies as well, with a mean cutoff of 4.28, and weighted sensitivity and specificity roughly 56% and 95%, almost at 96% respectively. So looking at those points from all the articles in summation, there was a higher specificity contrasting against sensitivity in nerve conduction studies. There are a wide range of cutoffs used in the literature, as you can see, with the ranges for both the sensory and motor latency, which can help or mar the interpretation of using these cutoffs and which cutoff is best. Just to illustrate this point, there are 2 articles that reported 100% specificity with respect to the distal sensory latency using 2 different cutoffs at 2.9 and 4.0. And then severity also matters. So the largest study in this review was the 1987 article by Stevens, which low incidence of carpal tunnel symptoms in a population can lead to low sensitivity. But this article did have a shortcoming as having no controls and was retrospective in nature. And then looking at the existing literature there, you can see that the Kimara article from 1979 did have controls, but the standard deviations overlap significantly between the control group and the carpal tunnel group. You can see there, as well as in looking at the article for Moon, that did have clinical controls using the cutoffs for distal motor latency of 4.4 and sensory for 3.5, had a sensitivity and specificity of both roughly around 50%. And then going on to the Chang article, looking at, they looked at roughly 100 patients with clinical carpal tunnel symptoms, and roughly 70% of those with either had an abnormal distal sensory or distal motor latency. And in isolation, there's a much lower percentage of people with clinical carpal tunnel symptoms that you catch with electrodiagnostic nerve conduction studies. And then also, one thing they found in the article was using the 95% confidence intervals in a control population can be misleading by definition if you report that specificity. And looking at other literature, similar papers, there was a 2002 article this year by Jordan et al. That was a similar systematic review. It looked at the electrodiagnostic testing with regards to surgical outcomes from carpal tunnel release. It was 6 retrospective studies. Overall, the authors noted that they were all poor quality, but felt that they could report that electrodiagnostic testing was not needed if clinical symptoms were well defined, but may have some role in unclear diagnoses with patients. And surgery ultimately led to roughly over 75% to 93% with good outcomes. So they didn't note any difference in outcomes with the results of electrodiagnostic testing. Strength and limitations of this paper. It's a systematic review, so it's a comprehensive look at the literature, as well as, but it is limited by the studies that exist. And Dr. Fowler's paper found that there was overall a very low quality of evidence regarding the use of nerve conduction studies. Many studies didn't report both distal sensory and distal motor latency, and that really doesn't reflect the clinical practice. When you are evaluating these patients and evaluating the test results, you're going to look at both of these. So it's hard to know how to interpret just an isolated nerve conduction study finding. And then also that the study population is going to influence the overall utility of the nerve conduction studies. So in conclusion, there's significant variation in the literature that was established with the different cutoffs that were used, and there's a need for higher quality research regarding the use of nerve conduction studies in the diagnosis of carpal tunnel. And that's it. And then some additional references that I included here.
Great. Well, Trent, thank you so much for your excellent presentation and summary. And this is really a fascinating paper for me because, you know, carpal tunnel is so common, and it's always a question as to what to look for in the nerve conduction study. So we have Doctors Fowler and Domino with us tonight, and I'd like to invite you, please, to just share with us your thoughts as to why you did this study, you know, and the clinical relevance and what you think you'd like to share with us. Please go ahead. Thank you.
Cory, I can start.
Please.
Thanks so much for the invitation. It's a real honor to be part of this first journal club. I mean, some of the big things I think about with nerve conduction studies are, in some ways, just kind of pointing out the variation. And all of us in practice know that you send people to different nerve study people and you can get very different results based on the cutoffs. You can even see in this study that the distal motor and distal sensory latency had very wide ranges. And as Trent kind of very eloquently said, we can artificially manipulate the sensitivity and specificity of a test by changing the cutoff values. So I think he said it, but if you make your cutoff value very low, you're gonna have a very high sensitivity, but that's gonna be at the cost of low specificity. So you're gonna have more false positives. Or if you want to really be sure, you can make your cutoff values very high, and then you'll have almost no false positives, but you'll have a lot of false negatives in that scenario. I think there is a dogma that nerve tests are maybe better than they are. And I think that this study really points out how many low quality articles are out there. I think Trent showed it, it was over 2,000, and there's that study by Chen that I think they looked at 4,000 articles, and we can include 21. I mean, that's not good overall. So I think really it was for that. And almost, I think everyone knows I do a lot of carpal tunnel ultrasound research. For me, it was a way to really summarize the literature in a contemporary way so that we can reference it and have a good starting point. Cory, do you have anything you wanted to say?
No, I think you hit the nail on the head perfectly there. I think the biggest thing for me in researching all these articles was finding how wide of a range of values people use for their cutoff values, and how, like you noted, how someone could use the cutoff value of 2.9 and somebody could use 4.0 and both have sensitivity or specificity of 100%, and just the kind of wide range of values that everyone uses and the different results you can get. And as Trent said, I mean, all these numbers have to be taken into context together, and no single one can really aid you without using all the others as well. So I think that's important to know as well.
Thank you so much for sharing your thoughts, John and Cory. It's really great to hear from you guys about your paper. So there are some questions in the audience, and we're going to get to them. We want everybody to have a chance to ask their questions. But before that, I'd like to invite Dr. Hammert as our expert for tonight. Warren, could you please share your thoughts about this paper and relevant clinical issues you think you'd like to discuss? Thank you.
Are you seeing my presenter mode or are you just seeing the main slide?
We're seeing your slides.
Okay,
Perfect.
So thank you for the invitation to be part of this. I think it's a really neat idea, and I'm excited to be able to participate in the first one. So I think a lot about carpal tunnel syndrome, probably as most of us do. It's a very common condition. Honestly, I think more about kind of the outcomes of treatment, though, than I think about the diagnosis of carpal tunnel syndrome. And when I think about people that are leaders, certainly John Fowler is somebody that has always come to mind, really more so because of all the research he's done in ultrasound as opposed to this. So when I read this, I said, okay, John has to have some kind of reason that he's doing this to set the stage for something else he's going to do with his ultrasound studies, because he's certainly been on the forefront of that. But I really enjoyed reading it and kind of thinking about this in a way differently than I probably would have if it wasn't for this journal club. And the couple things that I think about when we have our journal clubs, I always tell our residents or fellows, the two things that I think are important is look at the study design. Was the study design well? Is it a good study? And then how can I use this in my practice? What's the take home kind of message or point? And so in thinking about those two things, I'll just kind of give you a few thoughts on them. And then I have some kind of questions to pose for the authors and the group as a whole, I guess. You know, from a study design, when you look at a systematic review, you know, there's certain guidelines that you're supposed to follow. And I think the authors, although they didn't specifically say they followed the PRISMA guidelines, if you look through that PRISMA guideline checklist, they basically did all the things that you need to do to make sure that you're including the appropriate articles, that you're excluding the appropriate articles. So I think it was a well-designed study. And when you look at the literature itself, you kind of have to figure out, what is it that we're trying to do? Do we want things to be more specific, or do we want things to be more sensitive, as was alluded to, because you can adjust those numbers to kind of make them show what you want them to show. And that's one of the inherent weaknesses or downfalls of any sort of electrodiagnostic parameters or any study where there's a range of results, because within that range, it's going to be either more sensitive or more specific, but it's hard to kind of find the balance where you get the appropriate level of both. And then obviously the biggest limitation, as was discussed, was that of all the articles, there were only a handful that were really of a quality to be able to report on. And so that's one of the things that creates kind of some challenges with systematic reviews. And you're putting together a synopsis of what is there, but you're not able to actually include or make it better or improve the data. You're just reporting on the data that's there. So when you think of kind of the whole process here, how can I use this in my practice? A lot of times electrodiagnostic studies are ordered before I see the patient. They've been ordered by a primary care physician or somebody else, and so they show up with them. But they are helpful when I have them. Other times where it's helpful, some of the insurances require electrodiagnostic studies prior to even considering surgery or approving surgery. This is particularly true for workers' compensation in New York. Sometimes they're helpful to identify other problems in the upper extremity, whether there's a radiculopathy, another site of compressive neuropathy, differentiating a diabetic polyneuropathy from a localized compression neuropathy. And then some patients just want to know, how bad is my carpal tunnel? And I think I can use it, electrodiagnostic studies from those parameters, to help find things that are helpful to the patient, help me get together with a shared decision-making and figure out the best treatment for that patient. And so when I think about kind of the points of discussion, what is needed for diagnosis for carpal tunnel syndrome in most patients or in most physicians' practice? I think similar to, there's not one examination maneuver that is going to make a difference and convince you it's carpal tunnel. It's a combination of the history, the examination findings, and then the ancillary studies, whether it's a neuromuscular ultrasound, whether it's electrodiagnostic studies, or whether it's a corticosteroid injection. And all those can be helpful. Those can also fluctuate at any time. So, you know, it's funny how the resident or the fellow will go in and say, yeah, the Tinel's is negative, and I'll go tap on it and it'll be positive, or vice versa. So I think depending on exactly how you do that examination maneuver, it can fluctuate. Same thing, I think if I got electrodiagnostic studies right now on my hand, they would probably be fine. And if I had an ultrasound, it'd probably be fine. If I did it after I'm out riding my bike, cycling, I'm probably going to test positive, because my hands always get numb and I know what it is. I know what to do. It goes away quickly. But I think depending on the time of the study, whether it's an ultrasound or electrodiagnostics, those points may vary as well. So in thinking about that, I guess my questions for the authors or anybody else is, how much weight do you put into these changes in isolation? As was pointed out in the article, they looked at them in isolation rather than taken together. And I think when you look at the electrodiagnostics, you're going to take them together. The other thing is, how do you manage a patient that has changes on the electrodiagnostic studies, but really no clinical symptoms? They come in and they say, I have carpal tunnel, and you ask them, they say it hurts when I type. Now my hands aren't numb and tingly at all, but you've got nerve studies that show an increased distal motor latency or an increased sensory latency. And so how do the authors use this in practice? Do they make recommendations based on these results, or is there something different than what I do?
I think, Warren, you made a really great point about not using the test in isolation, and that actually can affect the sensitivity and specificity a lot as well. So, if you're using them in isolation, the specificity may be pretty good. But if we start using distal motor latency, distal sensory latency, relative sensory latencies, combined sensory index, you start looking at 8 or 10 or 12 different tests, the odds are that one of those tests may be positive. And the question is, if you have 10 different tests on the nerve test and one of them is positive, is that really a positive? Is it a false positive? What do we do with that information? And so I think when you start combining the tests, even though it seems like it might be better, in some ways, doing all those tests may actually have an effect to make a higher sensitivity and lead to a lower specificity. And we all know for a confirmatory test, we want a higher specificity. So, and then to answer your second question about, how does this affect my practice? I would say that for almost all routine cases of carpal tunnel syndrome, so the classic nocturnal symptoms, radial 3 digits, paresthesias, I no longer order nerve studies. I use a combination of CTS6 and then ultrasound if I need it or feel like I want it. I really use some of these diagnostic tests for the atypical cases, people where maybe it is pain and not paresthesias, or it's in the wrong distribution, or sometimes in workers' compensation. And I think you mentioned the insurance companies. Some different insurers in Pittsburgh require the tests for surgery.
So those are all excellent points. There was a question by Stuart Proper in the audience, and it's something that I kind of thought about as well. He says that the bottom line is whether the results of NCS EMG would change your treatment, and are there any studies to show that this really changes the clinical decision making? So it really comes down to the point as to really, do we need electrodiagnostic studies for management of carpal tunnel syndrome? So John, you told us you don't routinely use electrodiagnostic studies anymore, and neither do I. So I'd love to hear from everybody else, in the group. Do you all routinely still use electrodiagnostic studies to make a decision for surgery? Dr. Hammert?
So I generally, if they have classic symptoms, I don't need them to make a decision for surgery. But they said, I do have a lot of patients that want to know kind of how bad it is, or say, do I really need surgery? And so if I have somebody that has symptoms and has severe changes on the nerve study, this is the one condition, or compressive neuropathies are the one thing that I'll actually say, there is some benefit to doing surgery, even though you're not too symptomatic. We want to protect the existing function of the nerve and prevent you from having irreversible damage. As opposed to arthritis, where I think we'd almost all agree that arthritis can be as bad as it needs to be at the thumb, and we can treat them at any point in time. But with nerve compressions, there is a point where you can't go back. And so I think it can be somewhat helpful. It's not kind of certainly the only thing that I would use, but at least it's a piece of the puzzle that sometimes I can use to help a patient understand why I'm recommending surgery.
I also think that it can be helpful as establishing a baseline for a patient. And for a patient who comes back in after surgery, whether it's from you or someone else that either hasn't gotten better or has complaints of potentially being worse. So, I don't use it on everyone. I probably do use it on most people, but it's mainly to have that baseline, although I wouldn't say it factors in primarily to my decision-making for surgery. If the study is truly quote unquote negative and they have clinical symptoms, that's a patient that I'll try to kind of wait a bit longer. And if they're still quite symptomatic, we'll talk to them about surgery, but that's another way that I use the test.
How about Trent and Santi? You guys are both from the University of Pittsburgh. So do you all routinely use electrodiagnostic studies before carpal tunnel surgery?
I think if it's very clinically evident, then we will make a clinical diagnosis, and if it's certainly correlates, then we will offer them surgery. I think in unclear patients, as was said, I think oftentimes they come in from outside either PCP or primary care provider orders EMG and then refers them to our offices. So like I said, I think they're helpful to have, but in isolation they can lead you down the long path, and we want to root them in a clinical history as well as exam, which is most often what we're taught here.
Yeah, I agree. I think that in my experience, I mean, here at UPMC, it's a short-lived experience so far, and mostly with Dr. Fowler. So I have not been using it a lot. But you know, it's a very similar experience though back at my residency in UConn, where although we did have not everybody followed this exactly, but mostly just with unclear cases. You know, if there was anything off or anything that we were just not sure about with that specific patient, then it was easy enough to order. But I think if the criteria meets the CT6 meets criteria for carpal tunnel release and their symptoms are straightforward, then there's no need for it.
Great. So the consensus seems to be that, from what I'm gathering, that we either don't use it or we use it sometimes for certain patients. Is that about right? I guess, and this will probably continue to change with time. There was another question in the audience from Emily Graham, and I think it's a very relevant question as well. That was also addressed in the Q&A. But the question is, what cutoffs do you use for the nerve conduction study in your clinical practice? And John, your study really provided very good evidence, you know, as to the DSL and the DML that you use. But for example, Warren, what do you use when you look at your nerve conduction study?
So I use a combination of things. I don't look at just one thing in isolation, we said, but generally I'll look at what the distal sensory latency is for the median nerve and compare it to the ulnar nerve. Same thing with the motor, and compare them to an adjacent nerve to get a sense is there more than 1 millisecond greater. And then the absolute numbers are probably about what the averages are. Around 3.5 for sensory and 4.5 for motor is kind of what I think of just as something easy to remember.
How about you, Carl? What do you use in your diagnosis?
Yeah, I mean, around those numbers, you know, again, they're certainly imperfect, but 3.5 and either 4.2 to 4.5, somewhere in that range for the distal motor latency.
How about you, Santi and Trent at UPMC? What do you guys use? I suppose it's probably based on this paper, right?
Yes, 100%. I use the 3.5 and the 4.5 again because I think it's easy to remember. Another thing that was mentioned was when you index it with a nearby nerve, so using the ulnar nerve or and comparing that to the median nerve, both at the wrist, and looking at that difference, which I've seen more and more reported on the nerve conduction studies as well. So we have started using that and looking at that again with greater than 0.1.
Before we go to the next paper, I wanted to ask John if he could only have one test, could only order one test on a patient with suspected carpal tunnel syndrome. Would you choose ultrasound or nerve conduction studies?
I would do ultrasound 99 times out of 100 for sure.
You had to ask that question?
I wanted to hear the answer.
Yeah, it has to be ultrasound. But John is the expert in ultrasound, so it's ultrasound for everything.
Right. I was lobbing it up for him, and it's actually probably a good transition to our next paper, frankly. Yeah. And since we're halfway through, if Harvey, if it's okay with you, we'll make the turn here.
No, please
Kyle,
go ahead. Yeah.
Kyle,
Yes.
Mike Newmeister here. Could I ask
please.
one question for the readership of hand? And it's
Please
John.
do. Yeah.
John, can you tell us what is the take-home message that our readers should apply from your paper?
So I think the take-home message is that you should personally evaluate your nerve tests. So how many times do people just sometimes look at the reports? And I think this paper points out there's a lot of variation in what the cutoffs are and what that actually means. And as we kind of just talked about, you should have a number in your own mind about what a true positive is. And I guess not just trust. We talk all the time, you look at your own MRIs, look at your own x-rays. I think you got to really critically look at your own nerve studies and have a reason why you're saying that diagnosis is correct or not correct.
Awesome, thank you.
Okay. Well, thank you. We're going to pass it over to Carl and for the second paper.
Great. So we're going to move on to ultrasound evaluation for incomplete carpal tunnel release by Dr. Tulipian and Dr. Rivlin. So Santiago, I believe you're going to be presenting.
Yes. Can you guys see that okay?
Yes, we can.
Yes, we see you.
All right, so I'm Santiago Rodriguez, one of the UPMC Hand Fellows. Thanks for having us here, and I'll be presenting this paper, Ultrasound Evaluation for Incomplete Carpal Tunnel Release. And I appreciate Dr. Tilba and Dr. Rivlin for being here and participating in the discussion. So as a background, incomplete release of the transverse carpal ligament is the most common reason for persistent symptoms after carpal tunnel release, requiring revision. We've seen that incomplete release can be present in up to at least 50% revision carpal tunnel releases, and clinical failure of endoscopic carpal tunnels has been reported as high as 6%. Ultrasound is an effective tool that has been coming more to head recently for evaluation of changes in the median nerve preoperatively, as Dr. Fowler has, we just discussed, and it's also now being studied to detect incomplete transverse carpal ligament release postoperatively by quote unquote trained sonographers. And I think that's a really important point, is that a lot of this talk, I think we should start thinking about how much training one thinks that we need in order to use ultrasound in the office. Historically, ultrasound has been restricted to trained experts, as its accuracy is quote unquote operator dependent for a lot of different uses. So as we said, ultrasound is becoming much more widespread. We're using it for injections, for diagnosis, not just preoperatively, but post-op surgical evaluations of changes in soft tissue, such as nerves, such as this carpal tunnel. It's inexpensive. It can show aberrant anatomy that may be important not only during surgery, but also post-operatively. It's painless, and it's questionable, straightforward. That's something that we have to ask ourselves, how much training we need for use of this. We've seen multiple studies. This one listed here, Dr. Fowler has his own that have demonstrated using diagnostic ultrasound and carpal tunnel syndrome, measuring the cross-sectional area of the median nerve anywhere between 9 millimeters squared. Dr. Fowler's paper talks about 10 millimeters squared as being very highly sensitive and specific for carpal tunnel pathology, for median nerve pathology in regards to carpal tunnel syndrome. Here we have images showing some of the reasons why we could use it. Again, measuring the size of cross-sectional area can tell us a lot about a patient's symptoms. The top right here can show aberrant anatomy, such as persistent median artery within the carpal tunnel there. So definitely a lot of uses for it. And the hypothesis of this paper was that an orthopedic surgeon with basic training in ultrasound is capable of detecting an incomplete carpal tunnel release. So one senior resident, one fellowship trained hand surgeon, and 2 general orthopedists underwent a brief orientation to ultrasound of the carpal tunnel by a certified ultrasound instructor. 10 fresh frozen cadaver forearms were used to create a model for carpal tunnel release. They, using an endoscopic carpal tunnel system, the transverse carpal ligament was divided from distal to proximal in the same format that you would probably see with anybody that does endoscopic carpal tunnels, small transverse incision, just proximal to the wrist crease. And the transverse carpal ligament was divided either 0%, 25%, 50%, 75%, or complete 100% in its length. And no pre-existing evidence of surgical carpal tunnel release was seen in any of the cadavers that were used. Each forearm then underwent ultrasound by 2 of the 3 blinded participants, who recorded the values that they saw as far as how much of the TCL had been divided. And in the event of a tie, a third observer was used for a tiebreaker. Following the analysis with the ultrasound, all specimens then underwent a full open carpal tunnel approach, and the percentage of the transverse carpal ligament the percentage of it transected was then measured. The technique that was used in this study, the wrist was placed in neutral position. Initially, a longitudinal view in line with the median nerve, as you can see here in picture C, was done. The probe was then rotated approximately 90 degrees and advanced from proximal to distal along the course of the carpal tunnel. The way that they demonstrated, or that they evaluated for incomplete release, was looking at a nerve making an abrupt transition between a superficial to a deep position, and a transverse hyperechoic line representing the transverse carpal ligament superficial to it. So here in these images, you see a transverse view following transection of the transverse carpal ligament. That is where the horizontal line is. In B, you can see a transverse view again following complete transection. Number 1 labeled there is the median nerve, and in picture C is the longitudinal view following transection. And so So here we can kind of start seeing what the difference is, along the different lengths of the carpal tunnel and what it looks like with the ligament released. And the outcome measures in the study were sensitivity, specificity, the negative predictive value, and the positive predictive value of partial versus non-partial carpal tunnel release. So the partial releases were grouped together, the 25%, the 50%, and then 75% transected. And the non-partial releases, meaning either the 0% or the 100% releases, were pulled together as well. The results of the ultrasound were considered either positive or negative if there was an absolute agreement with the amount of release after confirming with that open exploration in the end. The Pearson correlation, which is basically a measure of how closely related the ultrasound and the open surgical evaluation were, was used to evaluate diagnostic performance. And the alpha coefficient, which is a measure of internal validity, was also used to check whether there is an internal consistency, I should say, between the percentage of endoscopic release and percentage diagnosed by ultrasound. The alpha coefficient, just as a reminder, anything over 0.9 means an excellent internal consistency. 0.9 to 0.8 is quote unquote good. 0.8 to 0.7 is acceptable, and then so forth from there. So what was shown is that there was actually a 100% sensitivity and a 75% specificity using ultrasound to diagnose an incomplete transverse carpal ligament release. The diagnostic performance of the ultrasound by the surgeons that had just undergone that short training was 90% for accuracy, 100% negative predictive value in diagnosis of partial versus non-partial. There was a high precision, meaning very good reliability, and high correlation, meaning very high accuracy between the ultrasound findings and then the subsequent open evaluation results. There was only 2 errors out of 10 that were noted during the study. As you can see here in table 2, there was one with 25% partial endoscopic carpal tunnel release, which was diagnosed as a 50% release. And there was one with 100% non-partial complete release, which was diagnosed as 50%. So the ultrasound is, like we talked about, is an expensive, efficient tool that should break free of this expert sonographer only stigma. It has a high sensitivity and specificity noted by novice ultrasonographers for diagnosis of incomplete carpal tunnel release based on this study. We also know that it has really high values in terms of just diagnosing carpal tunnel syndrome and using it for things such as injections. It's a well-established tool for these different modalities. And there's been several studies that have aimed to look at high definition ultrasound to determine the complete versus incomplete release. Here we have different methods of determining whether it's release or not. You can see here on the pictures on the bottom right that there's an indentation, which is one method that has been used in the past to determine whether the median nerve has been fully decompressed or not. In the top right, you have ultrasound exam pictures showing an intact transverse carpal ligament in figure A. And then in figure B, there's 2 weeks after surgery. In figure C, it is 4 weeks after surgery. And, it gives a lot of information about the status of the ligament at that time and the status of the nerve. So establishing an incomplete release, if you know that is the reason for persistent symptoms after carpal tunnel release, then there's a high likelihood of success with revision surgery, as opposed to there being other reasons, scar tissue, whatever it is. It can be amyloidosis, even zebras like that have a lower likelihood of success. So it's important to establish the reason for persistent symptoms. Incomplete release has been shown that is often secondary to just a few millimeters of intact transverse carpal ligament, or even the most proximal edge of the palmar aponeurosis. And I think that's something important to think about when looking at this study. This study, released 25% as the lowest amount, and we're not sure if that really captures just a few millimeters of incomplete release. The cadaveric model, again, is in a similar sense, may not be the suitable tool to recreate, because obviously we don't have the post-surgical inflammatory changes seen with our patients. And we just need to establish some standardized measurements or findings on high definition ultrasound, such as, do you look at the transverse carpal ligament itself? Do you look at the size of it? Do you look at indentations in the nerves, the trajectory of the nerve, as was looked at in this specific study? So I think that, this study was an elegant study, the way that, it was performed. And, we need higher powered studies just to kind of confirm what they found. We need to, and then establish, are we going to look at the trajectory, the sigmoid trajectory of the median nerve, or are we going to look at the actual transverse carpal ligament, or we can look at indentation, and those are the things that are future directions. Lots of studies have been done in the past. Not only, a lot of these are just kind of showing the utilities that we have of ultrasound. As we've talked about, Dr. Fowler's done a lot of research in this field and showed that it's a cost-effective tool for first-line tests and diagnosis of carpal tunnel. And then, he's done surveys of ultrasound used by upper extremity surgeons and determined why some may use it and why not. I think some of that has to do with your practice setting. And I think probably a lot of it also has to do with comfort of using an ultrasound itself. There's a lot of in the literature, especially in the rheumatology literature, about operator dependent using ultrasound. And, this bottom study here basically looked at different reviewers. One of them was a 10-year expert. One of them was a novice who underwent slight training. And then they used ultrasound at different articulations throughout the body. And for instance, in this one study, they found that after a 10-month experience for a novice investigator, that the quality of their ultrasonography skills for multiple of the joints equaled or came close to that of the 10-year expert.
Great,
So,
thank you.
Thank you very much.
Excellent presentation, Santiago. I'd like to welcome Dr. Tulipin and Dr. Rivlin to make some comments about their paper as the authors. And then we'll have Dr. Hammert, and we'd like to establish kind of a take-home message at the end of this paper. So let's get to it. So Mike and Jacob, take the floor.
Well, thank you, first of all, for inviting us to be part of this. I really appreciate the opportunity to be part of the inaugural journal club here. I appreciate that you, Santiago, in your presentation, noticed that there are kind of two ideas that this paper is trying to get across. And this paper really is looking at two separate things. One, it's looking at this as a diagnostic tool for incomplete carpal tunnel release. We all have these patients who have failure to improve after a short period of time following a carpal tunnel release. And there's always a question as to what to do with that, especially in those patients where you don't have a pre-surgical nerve conduction study. Because if you have one of those, it's a relatively easy decision point to say, okay, well, we can get a new nerve conduction study. We have a comparison at their baseline. Having a tool, especially a tool that can be used in the office, or without requiring any sort of repeat intervention on the patient, to look at those and say, oh, this is a surgical problem rather than a problem of the patient's nerve anatomy or ability to heal their nerve injury, would be hugely valuable in terms of surgical planning and deciding if and when to intervene. The other point of the paper, and the point that I'm glad that came across, is that this is a paper really trying to point out that ultrasound is a hugely powerful tool, and one that does not require nearly as much expertise as we've all been led to believe. There's nobody with a better handle on hand anatomy than a hand surgeon. As long as you can read the ultrasound, you can understand what the meaning of the lines that you see on the screen are. A hand surgeon is the person who's best situated to correlate that with anatomy and with pathology. And for that reason, ultrasound, I think, is going to continue to make inroads. It's much cheaper than alternative imaging modalities. It's real time. And it can draw on the experience, both in deep anatomy and in surface anatomy of the surgeons who are using it, to provide some information that wouldn't necessarily be available, say, on static imaging like an MRI. So, I think in part that's tagging along on Dr. Fowler's point that ultrasound is this hugely powerful tool. But I think even more so, it's to say that this is a hugely powerful tool that we're underutilizing, because we have the ability to use it to a much more much greater effect than we've been using it recently. Mike, do you have anything kind of in that vein there?
Sure. So first of all, again, thank you for inviting us. And what I don't like about that paper is that it scratches the surface of a potential that we could be doing. I hate to belittle our own paper, but it really is just a superficial surface that we touched. There are so many more permutations that we could be looking at, and we try to be wise as far as the design of the study by really controlling for every variable. But as you guys pointed out, most incomplete releases may be very, very narrow. It might be tough to see. It might be tough in real patient. And unfortunately, cadavers are not the same as human beings. And we would love to know more about how the carpal tunnel behaves throughout the healing process. And we don't have that information. But we do know, as Jake said, that ultrasound is a powerful tool. And I will talk about Jake and I, because there are not many more novice ultrasonographers than the two of us. And if two of us can learn how to do this well, I will tell you anybody can. And as much as the ultrasound used to be a black box for both of us, or at least for me, I think this tool, understanding the anatomy, is exceedingly powerful. And it can be reassuring to the patient and yourself when the patient does not follow the path that you think they should be after a carpal tunnel release. The other limitation that I was going to say, that we essentially looked at only endoscopic releases. So we don't really know how an open carpal tunnel, especially a traditional open, not that most of us do that, would do with this investigation with an ultrasound with the post-op changes. So, but thank you guys.
Great. There is also, just to add on one more thing, I'm sorry, there's also a lot of equipment dependence in this too. We're using a not terribly sophisticated ultrasound machine, just the bedside one that our anesthesiologists use for doing like axillary blocks. We weren't using anything nearly as sophisticated as what they'd use in, say, a cardiology lab, or what an actual radiologist would use if you send somebody for a dedicated ultrasound there. Which I think is useful in that it's a little bit more clinically relevant if we're going to talk about trying to do something like this in the office. But it also does mean that we lost out on some information that we would have otherwise had in these patients.
Great. Those are great points. I'd like to welcome Dr. Hammert to give his expert opinion, and then we'll wrap up with some more discussion.
Okay, so I'll go back to kind of my 2 points, the study design and how can I use this in practice. And I think from a study design standpoint, I think some of the things that I had questions about have been mentioned. I think clinically, probably you're thinking that there's a 10% or a 5% incomplete release. And so it would have been really interesting to know, is this within the limitation of the study? Can a basic ultrasound determine this? Potentially, they've shown that it's certainly easy to teach a group of people that may not have a lot of experience how to do the ultrasound and diagnose this. But can they diagnose a ligament that is 10% intact or 5% intact? From a standpoint of equipment, now they have handheld ultrasounds. So you can get one from your iPhone basically and do that. I wonder if that is sophisticated enough to do this, because that would make it more clinically easy to use for everybody if they don't have to have a machine, because probably not everybody has a machine in their office. When I think about how do I use this in practice, what is my take-home point with this? I guess I have a couple questions, and in part I will say I'm a complete novice when it comes to ultrasound, so I can do some basics, and I'm sure if I spend a little time I could learn how to determine, is most of this ligament released? In general, if I've done the surgery, I'm leaving the operating room and I'm 100% sure that that ligament is completely released. And so I think the times that I see patients that I wonder are usually ones that have been done by somebody else, and it's not at the first post-operative appointment, it's usually a few months down the line. And so as a ligament reforms, we've all kind of gone back and done a revision carpal tunnel release, and it's hard to tell what scar, what is actual the native ligament. As this ligament reforms, can we determine at 2 months or at 6 weeks or at 3 months, what is native ligament versus what is scar? And I don't know the answer to that. That would help me figure out, can I use this in practice? How does the nerve change afterwards? We probably think that electrodiagnostics don't improve or don't return to normal if they're severe. How does the ultrasound of the nerve change once that ligament has been released? And does it differentiate between a 50%, 80%, or 90% release? from that standpoint. And so if I look at kind of my discussion points that I had here, what creates a suspicion for incomplete release? Is it just that they still are symptomatic? How long does it take the ligament to reform? Can you tell the difference in the reformed ligament or native ligament? Then my questions for the authors again, do you routinely use this clinically, postoperatively, to look at your ligament releases? And then what do you do if your symptoms are better, but you look at the ultrasound and you see an incomplete release? You say there's still ligament there and the patient says, I'm doing great, doc. What do you do?
Thanks. Those are great questions. Let's turn them back over to Jacob and Mike, particularly the routine use of ultrasound post-op from carpal tunnel release, as well as the, I think, very important question about in a live human patient, the ligament reforming over time. Do we know what that looks like? Because this was a cadaveric study.
Yeah. So for question number 2, the only thing I would say is stay tuned. We hope to have that data to you in the near future. In terms of routine use, we do not use this yet. It's still pending the results of studies in actual humans. And I think it's very relevant that this is a cadaver study. There are a lot of differences between cadavers and living people, including the question of what the time course of repair of that ligament looks like. It may be that a postoperative hematoma or even just postoperative soft tissue swelling totally disrupts our ability to look at any of this. We won't know that until we have the data from the next study. And then in terms of what if the symptoms are better and you see incomplete release, my thought on this would be that if the patient's coming back with symptoms that are better, we wouldn't be getting an ultrasound in the first place. It would be looking for something that maybe we don't necessarily need to know the answer to.
Good points. And for some of the more expert folks out there, maybe John, you can comment on this. Have you noticed a difference between, or seen enough to notice a difference between open and endoscopic carpal tunnel releases and what they look like postoperatively? Does anyone have experience in that?
Yeah, we actually just recently published a study in, I think it was Journal of Hand Surgery, Global Online, which maybe we shouldn't talk about on this webinar, but it was actually looking at the differences between mini open and endoscopic carpal tunnel. And we were mostly measuring the median nerve cross-sectional area, but I looked at everything and I really didn't think it looked a whole lot different. There was a little more scar tissue superficially, kind of superficial to the transverse carpal ligament, but they seemed like they were equivalently released.
So Carl, maybe I can just make a brief comment. I do a fair amount of recurrent surgery, and I've gone back on other people's open and endoscopic carpal tunnel release, and it looks the same.
Yeah, I think that's been a lot of our clinical experiences, but I wonder if that's something that it's easily discernible on ultrasound, particularly for us novices. I mean, I do use one in the office, and I would say I'm average at best. I think the more you use it, the better you get. But this certainly is a tool that's going to be more prevalent in the future for all of us, I believe. Mike Rivlin, any comments from Dr. Hammert's questions?
Yeah, no, I think one of the most challenging things that we do as hand surgeons is to decide when to go back on somebody when you know something was done the right way. Whether that's your patient or some of your colleagues or neighbor hand surgeons, when do you pull the trigger of going back on a revision carpal tunnel? Because there are a lot of questions. How do you decide when you actually worry about an incomplete release? And I don't think any of us have the right answer. So I want to consider ultrasound as just an added tool when you are worried and you want to have just one more data point. It may be helpful for that decision making, but by no stretch is it the only decision point you need.
Dr. Hammert, any other thoughts from your experience?
No, I think as has been alluded to, this is probably the first step, and the next step is getting some data in living humans and seeing what it looks like. And I guess the comment about if they're better, I wouldn't do an ultrasound. I think almost that's the patients we need to do, because right now, I don't know what the nerve looks like after a complete release. Does that nerve still stay dilated? Or does that nerve shrink back to normal size? So if that nerve is 15 or 16 millimeters before surgery, does it look different at 10 days or 2 weeks? And so I think if we know what normally happens in patients that are doing well, it'll help us be able to interpret the data in patients that are not doing well. And I think John may have been doing some stuff like this, and maybe eventually somebody will have kind of some answers to what kind of the normal expectation is after surgery. And then we can figure out what's abnormal once we know what's normal.
I agree with that for sure.
But
So
it
let's-
takes time away from a practice that's busy and you're trying to get through to the next patient. So that's part of the challenge, for sure.
For sure. I'd like to, as we start to think about wrapping up, I'd like to ask the authors if they could give us a kind of really concise take-home message from their paper just to wrap up the discussion here.
I guess I would be start looking for ways to use ultrasound. It's easier to use, even if you have no experience in it, than you think it is, and it can be a very powerful tool. It's an open world out there, and there's a lot of opportunities to get to learn to use this.
All right, great. Well, we'd like to thank everyone very much for attending. I'm going to turn it over to Harvey to give some concluding words. Dr. Neumeister, thank you very much for attending, and we're so happy that we can share these excellent journals from hand. Do you want to make any comments as we start to wrap up?
Well, I got to tell you, it's very well done. I thank you so much for doing this. It's great to go through these articles. I love the discussion. And as we go forward, you know, there's all of us as surgeons, we have our own opinions. And when we have a study, we have even more opinions about those. The dialogue around those, it's just amazing to hear that from the people who are experts, from the people who are just starting, and from the authors. So I want to thank everyone for their contributions. And I hope this grows into something that we do on a very regular basis to increase the education of all of us. Thanks so much.
So I'd like to echo Dr. Neumeister, and certainly on behalf of the whole HAN and AAHS team, I'd like to thank everybody for your participation. This is really meant to be an engaging and interactive journal club, and really it's the questions that make all the difference. So thank you all for your questions. Kyle, you have some comments?
Yes, as you can see here on the screen, please follow the Hand Association on social media. We're trying to grow our efforts as an organization and try to engage as many hand surgeons as possible. Along those lines, please join the Hand Association if you're not already a member. Candidate membership is free for trainees, as you can see here, and we'd really like to see you in person at our meeting in January. Harvey and I are committed, as well as everyone else involved, to making these a success. So if you have suggestions, please reach out to us. I'm sure if you send an email to Sarah or Angela, who really sent out the details for this, we will welcome your suggestions and incorporate them into future sessions.
Yes, please consider attending the next meeting in Carlsbad, California. Here's the banner over here, January 11th to 15th. And we really hope that we'll see you all in person there. And please watch out for our next journal club. Okay, well, thank you so much, everybody. Any other comments, Kyle? I think
not really. There was a comment in the chat about CME credits. Thank you for that question. We're thinking about that, and stay tuned. It's not just like turning on the light switch, but we're really thinking about that critically. So thanks everyone for joining. We hope you have a wonderful evening, and we really appreciate the authors for participating, the fellows from University of Pittsburgh, and to Dr. Hammert for his expertise. Thank you, everyone. Have a good evening.
Thank you so much, everybody. Good night.